I'd like to welcome everyone back for our final session of the summit. Today's discussions are really fundamental to our focus here. This afternoon, we will engage in discussion to ensure that we have a defined roadmap, the tools, and the resources available to really build sustained research momentum. This is what's required to help us deliver on our critical goals for the inheritable bleeding disorders community. In each of the sessions during the summit, we've talked a bit about some of the necessary resources required to accelerate progress in the various areas. This is so critical to making progress, and in the session this afternoon, we'll talk specifically about how to develop the mechanisms to continually fuel critical research progress towards both our near-term and our long-term goals. So for the discussion today, we'll start with a short testimonial from Ziva Mann about opportunities to expand infrastructure and resource support. We're lucky to have Ziva share her perspectives with us. She describes herself as a perennially curious systems geek with a deep respect for the capacity of people, of communities, and of organizations to change their world. She's the Director of Assessment and Development at Ascent Leadership Networks, where she uses data and motivation to assess and develop leaders and their organizations. Previously, she worked in a wide range of roles, including patient partnership for redesigning processes, policies, and structures for team-based, person-centered care at Cambridge Health Alliance, as a faculty member for the Institute of Healthcare Improvement, the Gold Foundation, and core team for grants for the Robert Wood Johnson Foundation and PCORI. Her work for the Robert Wood Johnson Foundation has supported the development of generative, collaborative leaders working for health, equity, and well-being within their communities. She's also a member of NHS Board of Directors, and she lives with and loves someone with a bleeding disorder, living in Massachusetts with her husband and her sons. After that, we will turn to our plenary session, which will feature Dr. Charlie Bailey. Dr. Bailey is an expert clinical informatician whose work is focused on how the use of clinical and research informatics can help to improve the quality of pediatric healthcare and the overall health of children. So far, we've talked a lot about the use of novel technologies and data to help support our efforts. Today, so much research has been accelerated in ways not previously possible or even imagined through the use of advanced informatics. So we're lucky to have Dr. Bailey here to share his thoughts about how we can bring together research and clinical care through informatics and data sciences, specifically through the integration of clinical care and research through the use of electronic health records, and how these data can help to rapidly inform and to advance our research strategies and inform our research questions of relevance to the bleeding disorders community. So I think we're in for a terrific final session for the summit. I hope the summit has been informative and thought-provoking. This session will really carry us home. So with that, let's turn to the session.
Hi, I'm Ziva, and I'm the mom of two young men, one with severe hemophilia A, and I live with mild hemophilia. I'd never heard of hemophilia before my son, Shai, was diagnosed. It was scary, it was overwhelming, but we learned. We're still learning. When I was asked to join the State of the Science Working Group, I was a little surprised. I'm not a scientist. But I soon learned that Maggie Ragney, our working group chair, and the State of the Science team had this absolute conviction that our group needed to have people from different backgrounds, different voices and perspectives, that our work would be stronger by bringing all of us together. It was true for us, and as it turns out, it's also true for research. So research can be done by a few brilliant people in a lab, or it could be done by a network of people across the country, working and thinking together, sharing what they learn. Research can discover new treatments. It can also learn about what people in families like mine need in order to thrive. To live a life where your bleeding disorder is just a detail, something off in the corner. Medicine is just one piece of that puzzle. Medical records are just another. My medical record will tell you roughly how many bleeds I had last year. It won't tell you how that impacted me or the effect it had on my family. To understand what people and families need, we're going to need people and families living with bleeding disorders helping to plan the research, shape the questions being asked, explaining what matters to us and why. It means we'll have to be stronger by all of us working together. I'm really excited about the work that our working group's done. We found finding practical, tested ways to use partnerships for research, partnerships between researchers, hemophilia treatment centers, foundations, agencies, funders, more, always with people and families living with bleeding disorders at the heart of it, guiding and advising, because it's really going to take all of us to share and learn what we need to know so that people and families can thrive.
All right, and good afternoon. My name is Charles Bailey. I am a pediatric hematologist oncologist at the Children's Hospital of Philadelphia. I'm a clinical informatician who leads the informatics work in PedsNet, which is a national children's network, our national network of children's hospitals that is dedicated to advancing child health research through collaboration and data sharing. I'm really grateful for the opportunity to talk to you today about how learning health systems are one vehicle in which we can bring together the process of providing care to patients and the process of using the information that we learn when we deliver healthcare in order to get better at what we do. So I want to start out today just with some simple housekeeping. I have no conflicts of interest to disclose, but I do want to just be upfront about saying that because I'm talking about pediatrics and because much of what we do in providing care to children lags a bit behind our regulatory research, I am sure that I will in some cases mention off-label uses of a medication or a procedure which may be well studied but does not have a formal indication. More importantly than that, I want to start out by acknowledging that everything I am going to talk about today is built with the collaboration and the trust of a huge population of patients, families, and clinicians who are members of the health systems that PedsNet draws its knowledge from. So I've listed the PedsNet institutions there, and each of them provide care to a wide range of children, ranging from sort of healthy children who are getting primary care to children with a variety of complex medical disorders, including hematologic conditions. I also want to acknowledge the work of folks in the Data Coordinating Center at PedsNet and secondarily PCORNet in making both the network possible and in contributing to the knowledge that I will be talking about. All right, so with that in mind, I want to start by talking about the role of data science in our undertaking of clinical care and of medical science. And I will acknowledge that data science is something of a Rorschach blot, right? That the term can mean any number of different things to different people across the range of applications, from engineering on the factory floor to keeping the financial system running to delivery of healthcare. So in that respect, I want to talk specifically about data science as it applies to healthcare and to learning about the health of children and adults. And by that term, I mean the science of using data intelligently. So this is a science that's going to blend a number of disciplines, right? Some of which are traditional. We think about statistics and epidemiology as helping us understand how to ask good questions about large groups of people that tell us, we hope, more accurately what's going on. But we also draw from computer science that help us to be intentional and reproducible about the way that we structure our data so that we can take from it the knowledge that we need. And fields like linguistics and management, which have to do with how we behave when we go to the doctors, provide medical care, decide what is healthy and unhealthy, and how that affects the data that we collect, right? So in that respect, I'm going to anchor what I'm talking about in a concept called a learning health system. And that's a term that's gotten a lot of press in the last 10 to 15 years. But I want to be clear that this is not a new idea, right? So I am showing you one of the earliest recorded voices in Western medicine, right? This is Hippocrates. And 2,500 years ago, Hippocrates was talking about concepts in the oath commonly attributed to him, that such as the goal of the practice of medicine not being engendering knowledge or becoming an expert, but actually taking care of the sick, right? And built into that was the concept that we can't just collect information for ourselves, that both learning and teaching are an integral part of the way that we need to be practicing medicine or practicing any discipline that approaches the health of individuals, right? So how does that factor into the way healthcare systems now operate now? Well, we have a bit of a gap between the way we want to learn and the way that we ought to learn, right? So we have based a lot of what we consider reliable knowledge on the randomized clinical trial or the prospective study design. There are some excellent reasons for that in terms of reduction of bias, but we have to understand that those are ways of learning that create ideal situations, but are hard to get to. They're very expensive, not just in terms of dollar cost. One estimate, for instance, gave a figure of about $42,000 per patient studied for a well-designed randomized clinical trial, but also they're expensive in terms of the opportunity cost, right? Whom are we not seeing when we base our knowledge on a randomized clinical trial of 200 or 500 patients? Right? Secondly, we have to be careful that idealized knowledge tells us about idealized results, and the gap between how things perform in a perfect world and how things may perform when we actually take care of people can be large, right? We're stuck there because in these ideal designs, collecting bespoke data is hard, collecting perfect population is hard, controlling the world around us is hard, right? In addition, we have to think about where we want to go with those results. Certainly, we want to know about how effective or how efficacious drugs are, procedures are, prevention methods are. But we have to understand that knowing something is not the same as doing it. Again, one of the things that causes us to sort of heave a deep sigh in hematology is if we step outside bleeding disorders and look at sickle cell disease, right? There's good evidence that screening Doppler ultrasounds are the best predictor of risk for stroke in kids with sickle cell disease. There's also good evidence that 2 decades after that was known, the adoption was still incomplete, right? Because getting something into practice is hard. It's hard to pick up the knowledge. It's hard to know how to apply it. It's hard to cover the resources that are needed. It's hard to reach people who are not in a position to take advantage of healthcare resources. So part of what we need to do is account for those factors when we learn about health, right? So that leads us to the sort of modern notion of learning health systems, right? And I'm taking from the way that this concept was articulated in an IOM report a bit over a decade ago, right? The fundamental principles being that each time we deliver healthcare, each time that we meet a patient, each time that we meet a family, this should not just be an opportunity to apply our expertise, right? It's an opportunity to learn how to take better care today using everything we know about everything else, but also to learn from the care we delivered today, how to deliver better care tomorrow. So what that means is that we have to change the healthcare system so that it can learn too. It's not enough that we develop expertise in bleeding disorders or that we develop senior hematologists who know what's going on, but that the system is continuously learning how to do this better. I want to say, and I apologize for the fact that the wrapping appears to have been lost in the translation to the presentation slides, that this is not just good science, this is also good ethics, right? That part of what we all do when we seek healthcare or have a relationship with clinicians is we place our trust in them to be doing for us the best that can be done. And that's a reasonable expectation. We all know we're imperfect, but we should be trying our best. And part of trying our best is using all of the information that is at our disposal in order to better deliver healthcare. So what does that mean? What kind of things does a learning health system have to be able to do? Well, if we're talking about delivering better healthcare, it has to be able to operate in the place that we deliver healthcare. It's not enough to say that under idealized circumstances with lots of dedicated resources, we can achieve a certain outcome. We have to know what we can do when we actually meet patients. We have to engage participants across the spectrum, right? To work well, we have to engage not just physicians, but the entire clinical enterprise, not just hospitals and clinicals, but the entire system that stands behind them managing the resources available, not just the delivery arm, but the patients who are participants in their care. They're not passive recipients of that care or our expertise. We have to acknowledge that we're all aiming for better health, that that's a necessary goal. Knowledge is good, knowledge is not enough. Resources are good, resources are not enough. Access is good, access is not enough, right? What we want to get to is better health. And to get there, we have to ask hard questions about what it takes to deliver that healthcare pragmatically, not just what we could do in an ideal circumstance, but turns out to be unachievable for most patients. Okay then, what does this mean in practice? I talked a little bit about the randomized controlled trials. So what is our classic approach to data management in informatics and research? We're very focused on cohorts of patients who are recruited into studies and followed over time, or who are part of a clinical trial. So we can get very detailed data about those patients. We can learn a lot about them because we control what data we collect. And so we can say we need to know exactly this. But what we're not so good at saying is, while I'm collecting information now, how might someone else tomorrow be able to make use of that? Right now, when we need to answer a question, we stand up an infrastructure to answer that question. We get exactly the data we need, and then we set it aside. Right? We have gotten better about expanding to registries as a place in which people who have common interest, whether from the patient or the researcher perspective, can come together and who can collect information over time. This is a step forward, but its reach is incomplete, right? And its reach is uneven. And so part of what we're doing is trying to expand our scope to large populations, or to what we call common data element initiatives, agreements that we will collect data that look the same and that are reusable over time so that we can follow patients. The issue, again, like bespoke data, is if we say we are going to create new common data elements, or we are going to enroll into new cohorts like the All of Us program, that's very expensive because there are wheels that we're reinventing. So part of the learning health system model asks us, how can we use the places of care and the data collection tools and the kinds of data that we already collect, right, in order to better support improvement of health? So in the learning health system, we notice that we take care of patients with both acute and chronic conditions, so we have longitudinal follow-up. That we are moving into an era where more and more of the information we record is in a searchable format, right? It's in electronic health data. It may be buried in structures that are hard to search, imprecise terms, narrative histories, things like that, but we can reach it in a way that we couldn't. And we notice that we are developing the infrastructure to do things like collect information, but not just information, if patients are willing, also biospecimens, so that we can do additional research without having to stand up a completely new infrastructure to better ascertain populations of interest. We are getting better at getting data from patients. So we are better at deploying patient-reported outcome measures that are well-formed and well-tested and can reach people who are coming from a number of different cultural experiences. Right? We are certainly seeing an interest institutionally in engaging patients both within the building and outside the building. So we're building potential there for collaborative learning. This is not information that the health system delivers to you, but everyone participating in the process of learning. And most importantly, we're talking about deflecting outcomes, right? So we're asking, what can we do in addition to learning about the mechanisms of disease and the mechanisms of therapeutics? What are the questions that we have to ask to change the outcome? And what are the kinds of things we have to know when we're changing the outcome, so we can talk to the people who can change the outcome? This is still a painfully slow process. I'm showing you another small piece of data from a prior PETNet study that is looking at a situation in which there is a lot of published evidence about the efficacy of a particular therapeutic intervention, right? And you can see, just based on the efficacy across different healthcare settings, the adoption of these practices range between 0 and about 15%. This was not new data, but we were relying on passive adoptions. Noticing that, the relevant specialty society created a set of clinical guidelines that tried to highlight not just the importance of this intervention, but how one practically deployed it. And if you look at time going by, once the guidelines were published, there was an increase in adoption, but we're talking about a move from 10% to about 17%. So clearly just getting the information out there is not all we need to do to get changes implemented. Okay, so I'm talking about informatics. So let's start by saying, how do you get to the data you need? I'm stealing some words from Florence Nightingale here. The first thing that we need to do is stop being afraid of our data. Stop considering our data to be just a risk. Be intentional, be smart about the risks that are inherent in data. But one of the things that is remarkable about us is that we treat medical data in a very different way than we treat most of the other kinds of data available about it. And much of that is driven by fear. The fear that if someone knows something about healthcare, they will use that in a nefarious way. I won't say that that's impossible, but I will say that that is not the only thing going on. And I have met not only investigators who wish they had access to more data, but I have met large numbers of patients and families in pediatrics who are intensely frustrated that we are not using the information that we are gathering in order to take better care of their children because we're afraid of the responsibility that that data brings. Okay. So we need to think about where we get our data from, right? We need to move outside the doors of the hospital and ask, what of these other ways can we use to gather data about the majority of our life experience and the majority of our health experience? Where are we contributing data to other sources like registries or public health data? Where is it possible to reach out to interested patients and families and solicit data about their experience? And where is it possible to connect with people who want to provide information and get that information without taking up a lot of their effort, either through passive data collection or through generalization of information that you can share that we can then map to things like area level measures. So first step, where can we get data? Let's think more broadly about that. This is where a network like PedsNet comes in, right? So PedsNet is a collaboration of multiple children's hospitals across the nation. You can see from this density map that there is a presence in most of the states of the union. Our goal is to share the information that we learn from patients, that they share with us, that we learn from clinicians, that they gather as part of their care, in order to better understand what's happening with children, not just in Philadelphia, not just in San Francisco, not just in Seattle, but across the country and across the population. The result of that kind of approach at scale is that we can get to information that we need, excuse me, with both accuracy and depth. So I'm picking again a non-hematologic condition to give you a sense of what the diversity of experiences might be. So we're talking about relatively rare condition, glomerular disease in children. We can accumulate thousands of people, and starting with that size cohort, we can then start asking questions about who has been treated in what way, what have their outcomes been, what healthcare have they needed, in order to detect rare events or in order to detect patterns that it's very hard to see in smaller cohorts. What this requires is cooperating with each other. What this requires is moving beyond the notion that I need to do my study with my patients because it is my career, right? And saying what I need to do is look out for patients who have this condition, and I'll talk to anybody who is willing to engage in good faith, right? I will say that the PedsNet, which is focused on child health, operates within the larger context of PCORNet, which is a network nationally that spans the entire life cohort, the entire life course, sorry. So PedsNet is one of 8 health system networks. Some of them are regional networks, some of them are delivery system networks, some of them are specialty networks, right, that are asking the similar questions across the nation, right? So if you look at the scale then, that moves us up to about 70 million patients across the country with information on their health outcomes and with an ability to come back when we need to know more than anonymous data can provide and ask people, are you willing to be part of the conversation? And before we get to non-anonymous data, what are the questions that you want to answer? We certainly have to think about data privacy, right? And we want to think about the real risks, right? We want to think about not just the regulatory requirements that we have to meet, but what are the risks of de-identification, right? We talk a lot about that in a regulatory context. It means taking things like names and addresses out of data. one of the things we recognize is the more you know about my health, the more it is impossible to de-identify me, right? Because simply the pattern of what tests have been done, what medicines I take, what diagnoses I have makes me unique, right? So part of what these large collaboratives can do is advance the dialogue on good data governance and good data stewardship. On the other hand, we can also advance our knowledge about how to connect data in a safe way about patients. And we can advance our knowledge about what is part of the social contract and what people are willing to do, want us to do in order to learn better about their health, the health of their children, the health of their loved ones. So in that respect, part of what we can bring from an informatic perspective is technology. Right? So what I'm showing you here is a process called privacy protecting or privacy preserving record linkage. This is a method by which we can ask if a patient wants to participate in a study or if we're observing health of populations and patients move around between areas, it's possible to understand what care has been delivered in multiple places without ever having to ask, what's your name or what's your social security number? Right? So while preserving your privacy, we can gather the information that helps us learn about patient health. Right? I talked a little bit about what we call in informatics fact-based linkage. So the notion that without ever having to know who you are or without ever putting you at risk of someone being able to connect your name or face to your healthcare data, we can recognize when things are similar and learn from that. Right? So you can see the results of one particular study where we were looking at children who were sick enough to require ICU level care. And what you can see in this ROC diagram is that you can actually get to sensitivities and specificities well in excess of 90% without ever having to ask somebody about a risky identifier. Right? So part of what we're bringing here is the technology to learn more while reducing the kind of risks that have traditionally made us afraid of healthcare data. Part of what we need to know is what exactly is going on. Right? When we want to ask about a bleeding disorder, for instance, no one ever comes to us and says, my experience is M66.08. No one ever comes to us and says, I have the following RX norm in the refrigerator at home, right? So what we want to say is fundamentally, we need to know about what's going on with this protein, right? We give it lots of labels, right? So we may say that in the way we talk about a particular bleeding disorder, that we applied in the past 286.0 in the ICD-9 era. We may apply 28293.008 today. That's the way health systems talk to each other, right? We may call them different things. Hemophilia, hemophilia A, hereditary factor VIII deficiency. We need to know when we're all talking about the same entity, and we need to know that that's the entity we're talking about. We're not talking about the codes. We're talking about patients' health. That means from an informatics perspective, we have to be aware of the diversity of language, right? These are all different ways in a medical record to say that someone has factor VIII deficiency. And we need to know that these are all different ways to describe that same state of health, right? Otherwise, we're going to miss significant numbers of patients and significant opportunity to learn if we go back to a place like this and say, oh, we'll look for D66, right? So part of what informaticians are about is trying to translate the reality of the world into the structures of data. We also need to know how to use those data in a way that help us draw better conclusions. So what you're seeing here is the way that we think about drug names, right? So anybody who uses a factor VIII recombinant replacement product is using one of these products. But again, none of these names describe the totality of use of recombinant factor VIII products. And this is a bit of an old figure, so please recognize that not all of the products that are available now are listed, right? But they do all share the commonality that they are recombinant factor VIII replacements. And so when we're studying these groups of patients, we need to know what that commonality is, and we need to build structures into our data that let us ask these common questions without having to pick apart the details. Right? So this is part of what goes into design of electronic health records, and it's part of what goes into the design of research networks that effectively standardize and integrate data from a number of different care settings so we can ask meaningful questions. Right? There are over 1,500 ways to say amoxicillin when you're trying to pick a product off the shelf. That makes studies very difficult to conduct because you have a lot of elements to account for. They are all amoxicillin. And so if we can structure our data so you can ask who's taking amoxicillin or who's taking a recombinant factor VIII product, we'll be much more effective and our studies will be much more feasible and less costly. How do we do those things? So we do those things not just through vocabularies, but also through what we call common data models, right? And we are getting better and better about this, but we are still in an environment where different people have different common data models, and common is within the scope of one collaboration or one research network. Nonetheless, the goal is what we call interoperability, the ability of your data and my data and the data of the hospital in the next city to tell us about the same thing and for us to ask questions about the same thing. We need the data to be replicable. Right? What we do today has to hold up tomorrow and has to hold up 2 years from now so that we know there is not drift in our knowledge because the underlying data representations changed. Right? And finally, we need these models to make easy things easy. When I want to know about recombinant factor VIII, I need to be able to say that and not rely on knowing every marketed product now. Right? We need to make hard things possible. We need to say what are the limits of our data and how can we model data that are outside the scope of what we know about today so that we can learn better. And we need to be more collaborative. Right? From an informatician's perspective, I gave you 4 different collaborations that have 4 different ways of representing healthcare data. These are all models. So part of what we need to do is recognize that we can move back and forth between them and use the tools that are best adapted to the question that we need to answer. Right? So think of these not as barriers, but as opportunities for collaboration. What we want to do as well is think about how we are collecting data. And from an informatics perspective, we think of data structure on a couple of axes. Right? One is what we call discreteness. So how well does a piece of data in the electronic health record or elsewhere tell me about a specific thing happening in the life of a patient? The other axis we think about is how clear is that definition? How often is it the case that when the same thing is happening, we say the same words? Right? And we are really good at diversity of language. That gives a lot of flavor to what we say, but it's hard then to ask consistent questions. We looked, for instance, at the electronic health record just at our hospital, just for 24 hours, and we came up with about 100 different ways that people said this patient had a fever, right? So when you're starting at that point, almost any question becomes difficult. What we want is data that's out here, right? That's discrete. So when I'm asking about a specific fact, that piece of data tells me about that specifically and not 15 other things. And we want data whose definition is standard, right? Some of those things we can approximate, right? We have a standard definition for blood pressure, and we tend to measure it discretely. You get 2 numbers, a systolic and a diastolic number, right? We know what those are. We don't have standard definitions for hypertension. We have aspirations to standards, right? Similarly, we know what a partial thromboplastin time is, and we know how to calibrate that for the range between different labs, or we know what a Bethesda titer is, right? We don't know entirely about, or in any kind of detail, about the severity of bleeding episodes, right? And we don't tend to record them discretely. So we need to think about how to get data into a computable format. We do spend a lot of time up here in this sort of top quarter where there's some definition and some structure to the record, but you have to go looking for it. What we really want to avoid is this bottom left-hand corner, where we all tell stories about things in our own way and we make no effort to talk about it in common, because that's failing in our duty to try to maximize the knowledge that we gain from delivering healthcare. Again, I think of this less as trying to constrain our freedom to be accurate in what we record, and more as promoting our ability to collaborate and to learn to be up to the level of a first-class goal in our delivery of healthcare. The reason we want to avoid this from the informatician's perspective is when you get down into that left-hand corner and we have to recognize the 100 different ways that you say fever, or the 82 different ways that you say ear infection, or the 57 different ways that you say muscle bleed, then it gets really complicated, right? I'm showing you 3 pages of code here from a prior study where we were just trying to figure out when the clinician wrote down in a note a patient's ear exam, whether they were trying to say that ear was infected or not, right? This is the sort of thing that makes for very interesting problem solving, but it's the sort of thing that slows us down. It's not a simple problem to solve, right? We are not in a place where we can say, well, all right, let's just put a bunch of checkboxes in front of everybody, because that has downsides as well, right? We need to think about how to do this intelligently, but the process can be worth it, right? We dug in and we looked at those 82 different ways, and what we found was that 25% of the visits where we would, if we were looking at the diagnosis codes, have said this was an affected ear, were not, right? And so that would have seriously confounded our results. Or I'm giving you results from another study here where we were looking at sensitive behavioral indicators, right? So things that we ask people because they're important knowledge about their health and are critical to some studies, but they're not easy to talk about and they're not easy to write down. And you can see that when we make the effort from an informatics perspective to go to where the data live, the picture changes hugely, right? So the problem is not just getting better data, the problem is also how do we use the data we have? So one of our best answers there is to ask, what can we measure directly, right? This is Antonius Vesalius. The quote I'm stealing here is, I'm not accustomed to saying anything with certainty after only one or two observations. Certainly a quote that carried a lot of meaning from somebody who is an anatomist in the era where anatomical facilities were not very advanced. Well, we want to do the same thing. And so we want to ask, what do we measure? Here's another example from PedsNet outside the bleeding disorders area. We measure patients' heights and weights all the time, right? And so if we ask about obesity in pediatrics, we're measuring body mass index, not a perfect indicator of obesity, but one of the handy screening indicators. And you can see for any month of age prior to late teens, when kids age out of pediatrics, we have measured within this network alone over 6,000 of these measurements. Right? You can also see, interestingly, that people tend to go see the doctor around their birthday, and so there are annual spikes in our measurement. So what does that do for me? It means that we can look at how consistent we are in recording data. So this is health system to health system. How do we line up in the way we measure body mass indices? And the answer is we're quite close to each other, right? We can also ask, how do we compare to national standards? So what you see in the green line here is the NHANES data for 2007-2008. So this is a very carefully controlled national survey that puts a lot of effort into reproducibly measuring heights, weights, and BMIs for patients. How does that line up with the data that we're measuring in doctors' offices? Because one of the things that we always worry about is when you are not going out with bespoke data collection and trying very hard to control for potential error, you may introduce drift or you may introduce inaccuracy. Turns out you don't, right? So here we are measuring 6,000 people per month, and we get results across the age spectrum that track very closely with the data that NHANES is collecting. The biggest difference between us and NHANES is that because we're collecting thousands of patients and not hundreds of patients, our hysteresis is much smaller, right? So instead of the answer being scattered across all of these green points, we have a very good error bar on our estimate. So this is a case that works really well. And I'm not saying that everything that gets measured in healthcare works this well, but again, I'm saying don't be afraid of the fact that something is measured in the healthcare context. It may still tell you a lot of what you need to know. It may tell you way more than what you need to about what you need to know than looking at traditional methods, right? So here what we did was asked who got diagnosed with obesity, who actually met the BMI criteria for obesity. And again, I'm sorry that in the slide translation, the labels got rotated, but what you can see here is nobody except dedicated weight management clinics did better than about 27%. So if you built your study around diagnosis codes for obesity, you would be misclassifying 3/4 of your affected individuals. And you can imagine what effect that might have on the outcomes of your analysis. So when you measure something primarily, look at that primary measure. Know when you can use that to get to your outcome, and know when you have to ask about clinical judgment, right? Know when you have to go get data, right? There are some times that we don't have everything we need. And so part of what we need is to go to people and say, as part of this process, can you collaborate with us? Engage clinicians when you're talking about delivery of care, engage patients when you're talking about their life experiences. That gets you to the point where you are close to the patient and you get frontline assessment. It's not people 2 or 3 layers back in the data. It gets you a diversity of views, and hopefully it gets you a diversity of representations as well. It's not without its cost, right? Collecting data takes time, it takes resources, and we need to acknowledge that work. And we need to ask the people who will be giving us the data, what works for you? Right? Here's an example, again, taken from another study that participated in. Here we're looking at GI patients with inflammatory bowel disease. We found that we were struggling to know what the impact on patients' lives was, what their symptom burden was, how that changed their day-to-day lives. Everybody was interested in this. So we asked clinicians, when you talk to patients, can you capture that data for us? We'll try to make it easy and make it just a few clicks instead of having to either go into a different system and fill out a new form, or write us a whole case report form, and we'll pay you back. Right? If you collect this information, we'll write the note for you. We'll generate referral information for you. We'll tell you what care might be indicated based on evidence. So your value for giving us the 45 seconds to fill out the form, we hope is greater than the 45 seconds you would have spent doing other things we can now help you doing. That kind of collaboration is critical, because we all want to do better, but we all have 24-hour days. And so if all I do is come to you and ask for you to give more, then at some point you're not going to have more to give. What do we do with those data once we have it? So our first step in the informatics world is what we call phenotyping, once we've got the data quality established, right? And when I talk about a phenotype, it's again going back and remembering what I'm studying is how that protein does or doesn't behave. I'm not studying the diagnosis code. I'm not studying the prescription rate. So what is the footprint for the event of interest? Maybe it's not a discrete code. Maybe it's a cluster of things, or maybe it's a pattern of things over time. How do I discover what the data want to tell me, as opposed to imposing on the data my preconceived notion of what's right? What we often say here is that you should think outside the code, right? Look for larger patterns of behavior. And the reason we do this, to bring you back to the prior slide, is if we just look for the code, we're going to be wrong far too often. All right, so how do you get to good phenotyping? You have to ask yourself, what do you want to do? What do you have available to do it? Where can you test whether what you're doing is right or wrong, right? And finally, when we're talking about the informatics world, you have to ask about computability, right? You want to ask yourself, how can I make something work for me today, but how can I also make it work in the future so that I don't have to reinvent this wheel every time? Some considerations, right? We talk about assigned diagnoses, and one of the conventions and studies is to say all patients with a diagnosis of X. Well, one of the things you have to ask yourself is, do you really mean that? Right? So going back to that GI study that I mentioned a few slides ago, it turns out that far more patients only ever got one diagnosis of what should be a chronic medical condition than either got multiple diagnoses or started getting medications that we would expect would treat that condition. So that leads us to the question, when are you actually reaching the conclusion that you wanted to reach? And it turns out that not until you go out to this level of repetition are you seeing things that get you to the kind of sensitivity, specificity balance that you would want to use to design a study, right? Down here, you're losing a lot of specificity, and that may be helpful for screening, but it's not going to help you to accurately study patients affected by this health condition, right? If you look over time, what you can see is for a variety of disorders or for a variety of non-disease health conditions, it's common to have only one or two diagnoses. We talk about this in terms of what we call rule outs, right? So patients where we thought about this, but they didn't actually have it, or patients where we needed to do some testing and the code showed up because it's to justify the testing, but then things trail off pretty rapidly. And so you ask yourself, how would you like your computable phenotype to be tuned? Right? Here's the algorithm for Crohn's disease, looking at increasing numbers of diagnosis codes, and then the M tells you whether a treatment medication was present, right? And what you can see is if you set your threshold low, you will capture a large number of your patients, but your specificity will be lacking. The more you turn the knob on asking for more and more data, the more patients you may lose, but the more likely it is that a patient you identify will actually have the condition you want. and can either be studied in an observational study, or it would be fruitful to reach out to that patient for a conversation for a prospective study. Okay, that's the question. Then the next thing we want to ask ourselves is, what about the data? So we turn to our friend Socrates here, right? And one of the quotes that is often attributed to Socrates, know thyself. Well, in informatics, that's know thy data, right? What can the data tell you? So we talk about assessing data quality in a variety of ways, right? We talk about structural data quality. Do we have the kind of data we thought there, right? Are they missing? Do they not fit the model? When we want to talk about a diagnosis, but we look, it's telling us about a treatment, things like that. We talk about semantic data quality. Do the data mean what we think they mean? Are they perfectly valid? This is a prescription record and it's talking about a drug, but it's nonsensical for the patient. This is a valid diagnosis code for pregnancy, but you told us that the patient was male, right? And we ask, are the data fit for what we want? Do we have the amount of detail? Do we have the consistency in our data that we need to address this question? When we do this, we want to be systematic about what we're doing. So here's part of our history of PedsNet. When we started looking at data quality and asking what the problem was, the most common cause for a data quality problem in the network was our mistake, what we call an error in extracting and transforming the data. Over time, that number decreases steadily, and what we see is issues in what we call the data provenance or data characteristics, things that are just about the way we gather data, and we need to know them and account for them in analyses because we're not going to fix them in collecting the data. There wasn't a mistake there. We need to ask what kinds of errors can happen. So this again is looking at anthropometrics, heights and weights of patients. If you look at the causes of error in a data set that was composed of about 3 million measurements, you can see that a variety of characteristics that go to incorrect measurement are very uncommon, right? So none of these, you measured the number wrong errors, was present in more than about 0.5% of the data. What was present was the fact that we saw the patient a month ago and saw them again today, and instead of remeasuring them, we probably copied the numbers from the last visit forward. So we need to know about that because it's going to affect our analyses, but you're not going to fix that by going back and trying to get people to do more precise, more tightly controlled measurements of height and weight. That wasn't the problem in the first place. So fix the processes that are broken. As informaticians, we go through a process that asks, how do we get to good data quality, right? And this is conceptually not that hard, right? It's just, what do we want to do with the data? What kind of data do we have? So how do we translate the kinds of questions that we want to ask into the kinds of questions the data can answer? If we want to know about severity of a bleeding disorder, what are the data elements that are going to tell us about severity? If we want to talk about effectiveness of a treatment, what actually shows up in the data? Because there isn't going to be a data element that says my bleeding disorder is under good control. But there will be data elements that talk about how frequently I have to go to an ED, or how often I have to use a replacement product, or things like that, right? And then as informaticians, we also ask ourselves, what are the tools we have to better assess data quality so that we get a better sense of what's going on? For us, that translates into a process called study-specific data quality analysis, right? This is where we say, not just what do the data look like overall, but how do they fit the study? And you find out things like, if we're looking at prescribing, how can you connect what we know about prescribing one drug, a steroid here, with prescribing another drug, an antibiotic? And it turns out that the quality of data about the two is not necessarily well correlated, right? So our correlation coefficient here is only 0.39 between the error rate or the rate of prescription for a steroid and the rate of prescription for an antibiotic, right? So knowing about antibiotics doesn't necessarily tell us that we know about prescribing steroid metrics, prescribing steroids. It's not an easy thing to solve, right? It does turn out that the more patients you see, the less likely you are to have problems with your antibiotic prescribing data. Right? And some of that may speak to standardization of practice in larger systems. Some of it may speak to having data systems in place that help reduce errors, right? But there is an effect that health system size has. There is an effect that complexity has, right? You need to know where those effects are and how you can optimize them. And then what you can do is take those individual facts and fold them together. So this was a study looking at weight gain related to medication prescription. So what we can do is say, let's collect the information we know about data quality for antibiotics, for steroids, for other kinds of medications, for those carry forwards that we talked about in heights and weights, and come up with a composite measure of the data's alignment with the particular study design. And then let's look at how that unfolds in different sources of data. So here you're looking at a variety of different data sources across the study. And what you can see is there's a group of data sources down here that behave differently, right? And that have likely issues with the way that those data are recorded or extracted. And you need to account for that when you do your analyses, either by stratifying or by excluding some of your data sources so that you get more accurate results. You don't know that if you're doing just structural data quality, because everybody has data that looks like they're talking about medicines. It's just how accurate they are. This brings us back to the learning health system problem. So Ibn Sina, right, great Persian mind in thinking about, excuse me, the field of medicine. There are no incurable diseases, only the lack of will, right? And that's clearly looking over the long term, right? There's only the lack of knowledge. So we want to recognize what we know and what we don't know and always keep learning. From an informatics perspective, that means review how you define your data, right? If you come into a study saying, I want to look at something like height velocity between 6 and 12 months around a visit, you're going to lose about 1/3 of your population. Don't assume you know what the right interval is. Look at the possible intervals. It turns out with a small change, you can get up to 85% of your population, right? When you look at things like weight loss, right? Again, if you extend your interval, you can significantly increase your knowledge. You can significantly increase your ability to reach conclusions, right? So that you get to much more valuable data with small changes. See what you can add, right? So if you look at what data we were collecting in the IBD context, you can see that without moving the data, without making most use of the data, we may know about less than half of our patients, but the information is there without having to make it up, to go from 49 to 90% or from 27 to 60%. We just have to ask what the data are trying to tell us. So our job, again, is not to come impose our knowledge on the data. It is to be smart about asking, what are the data able to tell us, and to use that knowledge to generate conclusions, right? We can then get to we can then get to useful conclusions, right? And what we can do is say, let's look at remission by what the clinicians thought about what was going on, and ask, how is that mimicked in the data? And you can see that except for some lags in data collection, you see very similar patterns. So if you listen to what the data are telling you, you will come to, once again, very similar conclusions to what people will tell you with effort. But here you've spared them some of the effort. Some of that, from a data perspective, is how close are you, right? So I talked about this PCDAI disease index. The full PCDAI is 11 different elements of a patient's health. If you ask for all 11, you're going to know about less than 1 in 5 of your patients, right? On the other hand, you probably know about 7 of those elements for most patients. And so you can ask, if you do imputation to recover some of that missing data, do you change things? And what you see here in each type of imputation is there is very little shift as I impute more from these left-handed bars, which is what I would see if I only looked at the patients where I had all of the data. So it's telling me I can recover knowledge from the data by imputation without changing the actual accuracy of my measurement. And so I can learn a lot more about patients. What do we do with that? So let's ask Galen, right? We want to estimate effectiveness. All who drink this remedy recover in a short time. That's great, except those whom it doesn't help. They don't do so well, right? So these are the questions we want to answer, right? And taking that data about IBD, what we did is simulated a clinical trial. So the dark orange bars here are knowledge that was gained from intensive study of about 250 patients in a randomized clinical trial, $40,000 per patient, right? So we came along and used EHR and registry data to replicate that study. Again, we used a small cohort to try to get some information at about the same scale. And what you see is non-significant differences between what we're able to learn from the knowledge we already had at small incremental cost, under $10 per patient, right? Why are we not reaching out and using this knowledge? I'm not saying do away with randomized clinical trials. They are a necessary part of our armamentarium. But I am saying we need to stop thinking that they are the only valid way to look at things. Okay. What you can do is use that to predict whether a given treatment, here biologics, improves your remission rate. So you're seeing a standard Kaplan-Meier curve here, looking at the remission rate over time in treated versus control individuals, and you will see that by 12 weeks, there is a detectable difference in the remission rate. This is giving you information about the effectiveness of the treatment, right? That's a little different from efficacy. We're not telling you what the treatment is like in an ideal environment where we measure at exact intervals, right? But we are telling you in the real world, when you use this treatment, you actually see the result you would hope for. Similarly, let's look at what Picornet has been able to do. So this is the adaptable study. It's looking at aspirin dosing in patients who have had cardiac events as a way to try to reduce the risk of further thrombotic events. And it's evaluating different doses of aspirin, a problem that affects tens of thousands of patients, right? So this is what we call a pragmatic trial. Instead of a lot of feet on the ground recruiting patients and collecting data, patients were recruited by noticing in electronic health records when they might be eligible, reaching out to the patients and letting them decide and enroll in the study on their own. Randomization was done electronically and communicated back to people who are participating, and then the data were collected out of EHRs, right? And this study is recently published in NEJM, but again, we were able to establish that increased aspirin dose is actually not effective in reducing the rate of second events, right? Death, for secondary MI or secondary stroke. So the practice that is out there of saying once you've had a heart attack, you need a higher dose of aspirin turns out not to be borne out in fact, and we don't need to expose patients to the higher complication risk of that higher dose of aspirin. Right? Again, learn from the knowledge that we are collecting when we take care of patients. We're not going to get perfect answers, right? So we need to learn to live with the gray areas. As Osler said, medicine is a science of uncertainty and an art of probability. We never have a perfect answer, but don't be afraid of not having the perfect answer. And don't assume that if you have less than the perfect answer, there is nothing of value to be said, right? We don't want to go all the way in the other direction. We don't want to go so far that this is a black box and we have no idea what's going on, but we want to make intelligent use of the data that we have. So we are faced, as we try to develop learning health systems then, with this fork in the road, right? Do we take the path that maximizes our ability to collect all the information we have, to learn from that information and to use that to get better? Or do we say that perfection is the route we need to take and we continue to do small studies in tightly controlled conditions and only trust those, right? I would advocate that we need to add data science to our research tool set alongside the traditional tools of molecular science, psychometrics, clinical trial design. It's not about perfect data anymore. We need to add data science to our clinical practice. We need, when someone sees me, I can't rely on saying, I know my patients, or I saw someone who had this, right? There are tens of thousands of similar patients out there. What can I learn at the point of care? Right? How can I design systems that take better care and that guide us as clinicians in the right direction? How do we balance the kind of science that is relatively pure and gives us highly reliable knowledge in small doses with pragmatic science, which engages with the complexity of care and the complexity of the life circumstances that people come to the healthcare system from, right? This is going to require nothing less than reimagining the entire healthcare delivery and research effort as a collaborative effort in which we all work together to reflect our expertise in the method, in the pathology of disease and the methods of treatment, in how to run health systems and how to live lives, right? This is not about optimizing my hypothesis, my career, my institution. It's about working together to improve all of our health, right? Because we're all here to take care of patients. All right, thank you very much for your time. I'm very grateful, and I hope you found this interesting. I'd be happy to answer any questions that folks have.
Good afternoon. My name is Margaret Ragney, and I'm a co-chair of Working Group 6, the Resources and Funding subgroup. So the charge to our subgroup was to facilitate priority IBD research by considering registries and observational studies, clinical trials, and funding. This was a daunting task. And so for that, we sought out research experts as our resources. We looked at data collection. We talked about clinical trials, community partnerships, and funding, all as critical resources to carry out our task. So we envisioned an IBD research network within the HTC network that would be supported by a community lifespan registry, utilize an electronic medical record and machine learning that would enable observational studies, platform trials for all individuals, including hemophilia, mucocutaneous bleeding disorders, and rare bleeding disorders within the umbrella of the HTC network. And we envisioned that this research network would have the capacity for any patient within the HTC network to join a lifespan registry beginning at birth. And as risks or symptoms develop, hop onto a prevention or intervention or platform trial, or a predictive biomarker or observational study, or an industry post-licensure trial, all within the HTC network. So who are the research partners to sustain and support the research infrastructure that we are considering? Well, first and foremost, we heard from our working group that the community must be front and center in the engagement, planning, and participation of this network. We need an HTC network, including nurses, data managers, and investigators within which we would conduct research, a network database with common data elements and patient-related outcomes. We need remote visits and decentralization, as could be set up in a clinical research organization. We need foundations to assure we have sustainable funding for our research, and the NHF is our major support for oversight of funding and community engagement. We need IT partners for informatics, machine learning, and medical record data collection. We need the Hemostasis Thrombosis Research Society and the Foundation for Women and Girls with Blood Disorders to learn about models to sustain research funding and research training. We need clinical trials research networks to propose trial concepts and trialists to suggest trial design, statistics, and epidemiology expertise. So what are the tools that we require in our toolbox to assure that we can continue and sustain our research effort? We need a central IRB. We need master protocols and platform trials, small trial design and epidemiology expertise. We need biorepositories and data repositories, a common data element toolbox, as well as patient-reported outcomes toolbox, innovative design, which allows for historic controls, registries, and expert opinion. A community partnership is an essential part of this, as well as the ability to do decentralized trials right at home with drugs delivered to your home and simplicity. So we are thinking of a data registry as a way to set forth a platform for trials. But what are the requirements for a data registry to do this? The historic data must be robust. There must be predefined data elements that are collected. Data privacy and data confidentiality must be maintained, and patient protections, including informed consent, must be available. Historic data must be reliable, and it must be possible to do open label comparisons. One must be able to capture data elements to answer clinical questions and to be linked to data sets to provide time-sensitive data. Quite a tall order. So one of the possibilities that's really been available because of COVID is the idea of a decentralized clinical trial that allows for remote visits, telemedicine visits, at-home monitoring, home drug delivery, less restrictive selection criteria, allowing for decreased burden of participating in a trial. It's more personalized, convenient, and real-world settings at home, and translatable, as can be seen in this cartoon, which shows that it becomes fully virtual or can be done completely remotely. So what are the types of trials that we should engage in to do our research? We heard from our working group that the trials we have now are inefficient, costly, and take too long to get the results we need. We looked at adaptive trials that focus on frequent interim analyses, adding arms that are successful, dropping arms that are failing. These are efficient. They give earlier access to beneficial therapy, can simultaneously evaluate multiple drugs, and avoid the starting and stopping of multiple trials by doing it all within one platform. It uses common data entry, data collection. It involves the community from beginning to end in planning, designing, and participation. And it incentivizes our important partners, pharma, by providing early data looks and phase 4 trial data. It incentivizes our funders by novel funding and novel innovative strategy. And it incentivizes physicians at academic centers and HTCs to be the co-authors, to be the planners and the investigators, to train and to mentor. And here you can see in this cartoon, patients are enrolled, stratified, and randomized. Outcomes are recorded, and trial data are updated continuously with a statistical model updated based on those outcomes. Termination rules to determine if an arm is failing, that then is thrown out, and other arms are added, and the studies continue in a very efficient approach. Part of adaptive design is one approach, which is called responsive adaptive randomization. And you can see it here in 4 snapshots. In the first, the study initiation, where we're comparing drugs 1, 2, and 3 with control. And in the green, you can see our margin of superiority, and in red, the margin of inferiority. So by snapshot 2, patients are already being evaluated in an interim data update, and you can see that drug 1 is getting towards inferiority, whereas drugs 2 and 3 are moving up towards superiority. So there's preferential randomization to drugs 2 and 3, and in snapshot 3, you can see that drug 1 is now discontinued. It has failed. And in snapshot 4, you can see drug 2 has passed superiority. It now becomes the drug of choice in practice and continues on as a control for future studies. So this is very efficient. So as we were thinking about this research network, we wanted to consider what models would allow us to include an infrastructure and resources in the way that we were discussing a few minutes ago. And we considered several models. Here's model 1. In this, there is an HTC network with 6 to 8 regional hemophilia treatment centers and their local networks that works with an external data coordinating center that does all the high-tech work of innovative design, data banking, biobanking, decentralized trials, central IRB, informatics, and works with the community and foundations to assure that patients are enrolled and the research network is sustained. We also considered model 2, which is an HTC network with clinical coordinating centers at each of these regional HTCs and their networks, which incorporates and enables and convenes community members within a self-contained model with research design and implementation based on each of the expertise of our regional hemophilia centers. We also considered an HTC network coordinating center that was a hybrid, in which those 8 to 10 regional HTCs would do the work of coordinating and training and doing statistics, but for things in which they really lacked the expertise, they would have a data coordinating center, DCC, that would provide those additional resources for central IRB or platform trials or training. So what would be the elements of governance for this network? We envision an HTC network that would provide protocol review committees, federal partners that would provide external advisory oversight, patient community, also advisory oversight, and HTRS Athens, FWGBD groups that would provide external advisory oversight, and the National Hemophilia Foundation, which would not only provide external advisory oversight, but fiscal oversight. So who would be our funding partners to assure and sustain and support our research network? We envisioned that front and center would be the community that would be extraordinarily important in providing collaboration in planning and execution. HRSA, which would help support HTC personnel and the HTC trial infrastructure, the NHLBI to prioritize trial funding and support early science investigators and mechanistic studies, the CDC to promote surveillance registry to embed within trials, charities to help support registries, network, and community, foundations to help fund trials, and insurers to partner to measure outcomes, natural history, and using electronic medical records for research. Industry to help fund the trials, the networks, and post-licensure trials, the CTSA to leverage trial expertise and diversities, as well as tools for clinical trials. And finally, and most importantly, the NHF to develop foundation, nonprofit business models to help fund research. Thank you.
Hi, my name is Jordan Shavit. I'm one of the co-chairs of Working Group 6, and I'm a professor of pediatrics at the University of Michigan. As you know, my co-chairs are Guy Young, who will talk about infrastructure, Maggie Ragney, who will talk about resources and funding, and I will talk about workforce. First of all, I want to really thank the Workforce Committee. I couldn't have done it without them. This is a great, outstanding group of individuals. Starting here, we have Glivi Batsuli, and going around counterclockwise, we have Adam Suker, Mike Denny, Amber Federizo, Neil Frick, Leslie Ruffini, Glenn Pierce, Jose Lopez, Sean Job, and Lindsay George. Thank you guys very much. So one of our first tasks when we met was to define who is the workforce. Of course, there are primary givers like physicians, nurses, nurse practitioners, physician assistants, but we also have our support staff, nurses, social workers, physical therapists, hygienists, and genetic counselors. And then there are ancillary caregivers, OBGYN, oral surgeons, orthopedic surgeons, and even rheumatologists. And these individuals have, in some centers, have become a major component of the HTC. And then there's the research staff, the more traditional ones like laboratory scientists and data managers, but now we see a need for other areas like statisticians and informaticians. So we had some targeted areas for development that were developed by the parent committee. First of all, there's the workforce. There's the membership that I just talked about. There's the skill set of the future workforce and how we recruit, mentor, and retain them. But then there's how we train and fund them. And we wanted to look into novel and multidisciplinary approaches to training, networking opportunities, team science, including external expertise, and funding models, as well as team-based research. So we had to define the problem. There's a lot of presumptions when we look at what is the problem in terms of workforce. There is thought to be caregiver and staff shortages across the HTC, as well as the hematology workforce in general. There's difficulties with recruitment and retention. There's a lack of workforce diversity and inclusivity, and a lack of research staff to support efforts, both clinical and laboratory based. However, a lot of this is conjecture. There are some data out there that we found, but it's hard to know where the deficiencies are. Is it in pediatrics or adult? Is it rural or big cities? And of course, we have some ideas about that. But what are the reasons also? Is it money? Is it the academic opportunities? So it's really important to study this, and this we feel is the top priority. We're very good, though, at collecting data, and we can do this, I think, relatively easy. It will take some effort, of course, but we can look and we can see if the presumptions are accurate. We can get some quantitative data. We can find what the drivers and the barriers are. However, what we think is really important is that whoever is tasked with this needs to take these data right away and develop a clear action plan. Too many times we've seen data collected without action going on. And the action has to address the current issues, but also have a plan for ongoing monitoring at the local, regional, and national levels. So we divided our priorities, this would be done after the study, into 3 tiers, although some of it can actually be started now. So the Tier 1 priorities are areas that are primarily low cost but high impact and relatively easy in the short term to carry out. First of all, there's funding. When it comes to 340B funds, there are some HTCs that have done a really outstanding job of utilizing those funds and putting them back into what they were meant to in terms of clinical care and research to enhance patient care. Other centers have had more difficulty in achieving that. And so we'd love to see that bottom brought up and get those top centers out there and developing an expanded and comprehensive and standardized method of utilizing the funds that other centers can leverage. We should also leverage existing resources and not leave money on the table. NIH has a lot of training resources as well as other government agencies. There's foundations and societies, philanthropy and pharma, and this doesn't just have to be in the hematology space. There are other areas that can be tapped. Importantly, there really should be a centralized website to consolidate all this information and keep it up to date. So that way people don't have to go and look around and find, new, constantly be looking at websites to find this information. Workforce inclusivity is important, and we're not just talking about equity and inclusion. We'll come back to that later. But what we want to see is inclusivity of all of our current workforce members, the ones I told you about before. Most training programs that are available are only eligible for physicians, and we'd like to see that broadened to non-physician staff, as well as extend membership within professional hematology organizations for those organizations that don't include it beyond physicians. Lobbying is something that could be tapped into. There are current hematology organizational structures, and we'd like to see broader and independent recognition of hematology. For example, the U.S. News and World Report poll, where we see cancer rankings, but we never see hematology rankings. We'd like to see a broader center designation for hematology and certification. So Tier 2 priorities are areas that are primarily high cost and high impact, but in the midterm. We'd like to see development of partnerships among existing resource groups. We've seen that already. For example, HTRS and FWGBD have a partnership for membership. NHF, ASH, and ISTH have developed clinical guidelines together. We'd like to see partnering for developing the workforce. We'd like to see this targeted to areas of need. We could see recruitment of individual experts to either bring out trainees to their institutions, like the point-of-care ultrasound programs, for example, or do the reverse, send out the experts to individual institutions to do fellowships or mini sabbaticals where they can train the whole center. We'd like to see requests for funding applications specific to workforce that could be targeted to very specific goals, partnerships with external bodies, clinical and basic team research partnerships, and non-traditional and cross-disciplinary research. Tier 3 priorities are areas that are primarily long-term, and they're new, high-cost, high-impact projects. One main thing is development of regional HTCs in a sort of hub-and-spoke model, where the hubs have aligned educational, translational, and implementation research excellence. And what this means is that the workforce will have comprehensive skill sets. We would like to see bioinformatics and clinical informatics to look at next generation sequencing data and development of the electronic health record, respectively. Experts in clinical research, such as adaptive trials and other methodologies. Statistical experts, experts in certain laboratory technologies, molecular biology and genome editing or gene therapy. Of course, we want to work on mentees, prioritizing existing networking opportunities and programs, but also creating additional networking opportunities. And on the flip side, we don't want to just put in resources for the mentees. We want to really encourage and support the mentors. Get these faculty involved so that they will guide mentees. And this may include funding. For example, NIH actually has a grant called the K24, which will give 25 to 50% effort dedicated to mentoring. We'd like to see development of innovative new educational promotional strategies that will help increase recruitment and retention. We want to develop a multidisciplinary workforce that's long-term, and not just the physicians, the other groups that I mentioned as well. We'd like to see cross-disciplinary relationships. I've mentioned this already, but with other individuals and societies that have common interests. So both within hematology, but reaching out into these other areas. One historical example that I just love is the NHF gene therapy meeting, where experts in gene therapy, for 20, 30 years ago, who had no interest or knowledge of hemophilia, were brought together with hemophilia care providers that led to a meeting and many partnerships, and look where we are today. And then, of course, last but certainly not least, there's diversity, equity, and inclusion. We need the workforce to be trained, and we need and recruitment to ensure that the needs of underserved communities are met, that we can deliver healthcare in an equitable and inclusive manner. So I want to thank you for your attention. I am really looking forward to our open discussion. And then one more time, I just want to say thank you again to the committee members.
Hi, this is Guy Young. I'm here to talk to you about our working group 6 infrastructure for the State of the Science Research Summit for the National Hemophilia Foundation. I'm delighted to have been asked to be the co-chair of this particular group. I'm from Children's Hospital Los Angeles and the University of Southern California. Well, what is infrastructure anyway? So I think we all kind of know what it means. This is just one example of what infrastructure might be in our society, ranging from roads and airports for transport to energy, utility systems, social infrastructure, healthcare, education, etc. So here's our working group: Stacy Croteau, the director of the Hemophilia Treatment Center of Boston; Randy Curtis, who's our patient representative; Emily Crava is a research coordinator who works with me at Children's Hospital Los Angeles; Moses Miles, the chief operating officer of Athens; and Lisa Pittler, who's a lawyer and many other degrees, was a healthcare compliance professional and helped us with some of the regulatory aspects and suggestions for IRB topics. So with that, we all work together to put this slide set together to talk about the infrastructure. So here's the definition of infrastructure. And I think that for our group, basically it's this one: the underlying foundation or basic framework. So, like for a system organization, and we certainly have an organization, and this would be essentially the underlying foundation or basic framework for research, because we're talking about research infrastructure. Now, there are two types of infrastructure. There's study site infrastructure, which is what happens in your own center, your staff, processes that you use, and the other tools that are specific to your study site. There's also the common infrastructure. These are processes, tools, and services that are shared, for example, like plumbing. And these are reusable between study sites and between projects. So for common infrastructure, some of the potential common infrastructure would be a standardized and or automated data collection, such as what we have, for example, with Athens. Centralized IRB, standard templates and terms like contracts, consents, a shared electronic consent delivery system, shared biostatistics and project management services, and a collaboration site for principal investigators and research staff, hosting a repository of project opportunities and best practices for executing research projects. Also, biorepositories can be considered part of common infrastructure. The advantages are that it allows the community to create a common branding. So for example, here we are with the State of the Science for studies, while enabling each study to be managed independently. Studies operate with an agreed upon set of community defined standards. it leads to a lower barrier of participation for less resourced study sites, where they can leverage best practices, reusable tools, SOPs, for example, and services, reduce duplication of effort, and the potential to enhance comparability of research data sets. The study site infrastructure is, of course, we mentioned the people, processes, and tools at your site. And there are two types of processes and tools, those that are unique to the study site or their larger institution, and those that have the potential to be either standardized or centralized between study sites. And the capacity of a study site often determines the ability of the site to participate in a study. So how does this apply to research in general? So this is a pyramid of the different types of studies that you can think about. It's not perhaps totally complete, but these are the studies that we generally do, ranging from, on the low end, local retrospective studies. And this pyramid, if you see on the left, is basically built to show you what the site resource requirements would be. So what you have to invest in your site to be part of this research. So for example, at the bottom, local retrospective studies. This doesn't take a lot of work. You may not even need an IRB or get an IRB exemption, and you can collect your own data and report that out. And we see lots of retrospective studies done in hemophilia. The next level that takes a bit more work and a bit more organization involves registries or the Athens studies. Then we get to sponsored clinical trials. And while these cost a lot of money, they do come with a lot of resources. So I think that the site resource requirements are not as much as the next level, which would be investigator-initiated clinical studies. We have a few of these in my center where we are the central site, and I can tell you that's very resource intensive. And ultimately, basic and or translational research, which is quite resource intensive for sites. Who are the teams that we have to interact with? So if you're the study site team in the middle, you have, for example, the sponsor of the study, be it something like Athens or be it a drug company. There are CROs, central labs, the pharmacies, the IRB could be a central IRB, could be your local IRB, contract teams, and the clinical research unit where you might conduct a study. Who are the players? Who are the people involved? Well, I put the subject in the middle, and the people involved would be the investigators, the clinical research coordinator and or data manager, your local lab people, a pharmacist, an investigational pharmacist at your center, the IRB coordinator who may help you with submitting IRBs, and potentially a research nurse. What are the interfaces and websites? And mind you, this is the short list. I participated in a lot of company-sponsored clinical trials, and for some of them, there are 7, 8, 9 different websites for one study. These would include the IWRS system, which is essentially a system that is used for randomization and assigning patients to trials, as well as assigning drugs, which drugs patients may be randomized to receive. There are adverse event reporting, so the SUSARs, or the suspected and unexpected serious adverse event reporting systems that may have a website. Central lab reporting may come from a different website. ECRFs, there's the RAVE group, there's others, Medidata and RAVE, which are kind of the same. Local and central IRBs, trial management software that you may have to use. The electronic health record, which is, of course, where you'll get a lot of your source information. And then the sponsor site, protocols, investigation brochures, et cetera. So lots of interfaces. How does this apply to research in the HTC? Well, there's lots of different HTC types and affiliates. Some of us are in fully federally supported academic centers, like my place. There are also federally supported but non-academic adult and pediatric hospitals that have HTCs. Some may be affiliates and not be HTCs. There are federally supported non-hospital affiliated private HTCs. We know that a number of those exist in the US. And also non-federally supported centers that may be part of Athens. So lots of different ways in which HTCs are set up in practice. And research resources vary. There are centers with significant resources for research. They have lots of staff and they have lots of funding. They can participate in most, if not the full pyramid. And I point out at the top where these resources, where the funding can come from. Could be grants from the government or philanthropy, could be sponsored studies like pharma, or just general philanthropy, not applied necessarily to specific projects. So again, some centers have significant resources for research, some have some funding for research, so they can participate in some of the pyramid, but maybe not the whole pyramid. And there are centers where 1 or 2 staff members perform double duty. It could be the clinical nurse who also functions as the research nurse. And that really is a lot of work for those people, I know that. Generally, these sites may only participate in AFIN or the CDC studies. And in some places, there may be no dedicated research staff, where the HTC physicians or nurses will do the best they can to volunteer time to participate in AFIN, CDC, or even doing some of their own studies. So what should be the expectations? Not all centers can do all research. I don't think we should expect every center is going to do everything in this pyramid. But the goal should be for every HTC to at least be able to participate in the CDC community counts program, the AFIN data set, and AFIN Transcends. These are basically registries. Some have some blood draws involved. They do require some IRB as well. And funding and other support will be required to achieve this. So we want every HTC to at least be at that second level. We understand that many HTCs may not be able to do the levels above that. And if they want to do their local retrospective studies, certainly they can do that as well. How do we get there? Well, you've heard from Dr. Ragney. Her group will discuss funding sources. The other thing is that NHF and AFIN should work together with the centers to achieve some semblance of equity. So for example, if NHF and AFIN have funds, they may want to allocate more funds to smaller centers just to get everyone to the second layer of the pyramid. Or some of the larger centers like mine may not need as many funds to still participate in the AFIN studies or CDC surveillance, et cetera. We might want to get some assistance with startup for centers. So centers not getting the second level, maybe just some help getting started, getting things in line to just get to that point where they can do those studies once they're up and running. So we may need to do some assistance with startup. Maybe development of a centralized research hub for services aimed at increasing the capacity of centers to do research. So if there's a lot of stuff that's centralized and shared, you may not need as much work to achieve that second level to participate in those registries. And then provision of educational opportunities and training can help as well. So with that, I'm going to stop and join me and the other speakers at the live discussion scheduled right after this session. Thank you.